that was what Lee Judge had to say about health care. It's our community, and this is Mary Davidson, and we are welcoming Howard Wizig.
Thank you.
Howard is, and has been for a number of years, an expert on health insurance. And of course, as President Obama said, Howard, everybody has checked in and everything has been said and everybody has said it. But I don't think it's quite true. I think there's a lot more to be said.
Yes, there is.
Yes. Give us some sound bites on health insurance, health care insurance.
Well, I think the overall issue here that people don't focus on is that health insurance doesn't really insure your health. Most people think it does, but it doesn't. If I lose my arm, health insurance doesn't say, oh, your arm was worth $1 million to you, let me write you a check for $1 million. And if I lose my health and I can't work, they don't say, oh, you know, you can't work. You know, being able to work is worth $1 million, let me write you a check. That's really disability insurance. It does both of those things.
Well, and I think you have to separate health insurance from health care.
Absolutely.
You know, like pills and hospitals and that kind of thing.
As I like to say, we have one of the world's best healthcare systems. We have just one of the world's craziest financing systems as to how we pay for it. And the reality is, as I was saying earlier, health insurance doesn't insure your health. What health insurance insures is your finances, so you don't go broke paying to cure yourself when you lose your arm.
But you know what, Howard? There are an awful lot of people that have no health insurance and get terribly sick. Somehow they get into the hospital. There is no way in this world that they're going to be able to pay the bills that they have incurred.
Well, that's true. And part of that is because some would argue they've been irresponsible and didn't buy the health insurance to begin with. We have a system that's a little messy. If you're poor,
a little.
Well, if you're poor,
yeah,
we've got Medicaid for you. If you've got means such that you want to insure your finances, make sure you don't go broke paying for this, we have health insurance for you. And oftentimes, the majority of the time, it's provided by your employer.
Yes.
And we do have people who unfortunately find themselves in the middle. They're not poor enough for Medicaid, but they don't have insurance. And unfortunately, they've waited too long to buy it. Because
and
you can't
it's really expensive, Howard.
It's actually not as expensive as you think it is. My family of 4 has an individual health insurance plan for $550 a month. Actually, we were a family of 4, as you know, we're now a family of 3. $550 a month for a family of 4, $3,000 deductible, 100% thereafter. It's not that expensive. Now,
well,
that said, we did the responsible thing. We bought it when we were healthy.
That's right. That's right.
And it didn't go away, and it didn't get more expensive when one of us got sick, because as you know, my wife recently passed away.
That's right.
$1 million of medical bills, $500,000 after discounts, which is the other irony, as you mentioned.
Yes.
If you have the insurance, you get access to the discounts.
That's right.
The biggest value from your health insurance is not the insurance, it's the discounts.
A lot of people buy long-term health care. What it's you know, if you get in a home or something like that, is that a good buy?
That's a industry for other experts.
Yes, sir.
The issues with that are that people buy it when they're healthy and they tend to drop it before they get sick, and so the money that's made off of them subsidizes those who need the care.
Well, you know, we have chosen at this point to leave health care for profit organizations, mostly. Except, well, let's exempt Medicare and Medicaid for just a moment here.
Or Blue Cross plans that are not-for-profit, or not-for-profit hospital systems.
They might like to be.
Well, the reality is when the president vilified the health plan in Alabama that had so much market share as being a monopoly, that health plan, Blue Cross of Alabama, actually happens to be a not-for-profit plan. Blue Cross of Kansas City is a not-for-profit plan.
Well, in the new healthcare initiative, you know, I'm really not sure what the initiative is, but as we talk about it today, what is it? Is the government going to run it? How you know, what are we going to do here? Well, I mean, the Senate and the House are very different. Do you like either of them?
I like components of some of them. I believe that for the most part, they're going to be fiascos.
Why?
The
Why do you think
problem
that?
is none of those plans get at the underlying costs. They're so busy vilifying the insurance companies and talking about how they're going to subsidize someone's care. Well, subsidizing doesn't reduce the cost. It just means somebody else pays it for you. None of these plans get at the underlying health care costs that drive the health insurance premiums. Recently, the politicians have been vilifying WellPoint. In the California plan, they had 112, they had a big rate increase. Well, the reason they had a rate increase is the medical bills amounted to 112% of the premium. Well, you can't keep offering.
Well, who's charging too much, Howard? What happens? I mean,
in the health insurance industry, claims drive premiums. You have to cover your claims.
abuse is in there too, Howard.
Which type of abuse?
Well, I think charging for things that don't happen or charging for things that...
You make a wonderful point. And my point to this would be as follows.
All right.
One of the tragedies of both of these bills is they try to get at stipulating what the administrative fees can be. Now, right now, those fees are all regulated. When an insured product goes before a state insurance commissioner, the insurance company says, we're going to spend money on audits. And we're going to spend $1 here in extra admin and audits, and that's going to save us $2, and that's worth doing it. So it's regulated, it's reviewed. But when you stipulate it, you get into a whole nother host of problems, because if the new bills are going to say you cannot have, and the numbers vary by each of the bills, you cannot have administrative fees over 12% or 15% or 20% or whatever the percentages they settle on, well, the problem with that is you don't have an incentive to spend 50 cents to save $1.
Is this done state by state, the regulation of the...
Right now, health insurance is regulated at the state level.
So every state has something different that the Commissioner of Insurance...
For insured products. Now then what you have is many employers offer self-insured products that are not subject to state regulation. The state insurance commissioners hate it. They're also not subject to premium taxes, which the state insurance commissioners really hate. And those are covered under federal guidelines.
You know, I noticed that Senator Rockefeller referred to the insurance companies as rapacious. Do you believe that?
I believe we have a system that has flaws. However, we have a system where over 90% of the people have health insurance, and it's working for them, and they're happy with it. All of these programs are designed to increase the number of people with insurance by 30 million at the expense of 200 plus million. It doesn't make sense. Again, if they cannot get to the underlying costs, you will not be able to control the program. And the sad thing is that all of these programs, well, if we want to increase coverage and give everyone health insurance because we think it's the right thing to do, I'm fine with that.
Well, somebody, I heard that too, that there was a person, one of the talking heads I was listening to, and the idea was just junk the whole thing and go to universal health coverage.
Well, how we get there, how we provide universal coverage, whether it's through the government or private plans, et cetera, aside, the point is, if we want to do this because we say it's the right thing to do, that's fine. But don't argue it's going to save money. It will not save money. It will cost more money. And that's where I have a big problem with this. The reality is every single experiment that was going to save money has failed. Massachusetts is a fiasco.
Is it really?
It is absolutely a fiasco.
Because?
Well, one of the biggest problems is you cannot say to people that you can come in and out of the system at will, and we're going to waive your pre-existing conditions. I would love to only insure my house the day it catches fire. In fact, I'd really like to only insure it the hour it's on fire. But we're all laughing at that.
Yeah.
But the reality is, if you say I can wait until I'm sick before I buy health insurance, Mary, we ran up over $500,000 of bills in my wife's medical care. Okay? I own my own individual policy. I never worried about losing my job and losing my health insurance. I never got kicked out. I bought it when I was healthy at the right time. I bought it when I should have, and we were fine. However, with as much as I have benefited by owning my own insurance policy, if you told me I could drop my plan and buy it once I get sick, I'll drop my coverage.
Oh, well, that's right. You can save yourself $550 a month.
And once everyone does that,
Then we're
the
in
system
trouble.
implodes.
Then we're in trouble.
Well,
then basically we're all on either Medicaid or Medicare.
you've got a government runs, it will be a fiasco. Yeah. What insurance company in their right mind would offer a policy to someone who the only ones that are going to buy it is when they expect the expenses to be more expensive? We all know about the proverbial 80-20 rule. The reality is in health insurance, it's a much steeper curve than that. In health insurance, 11% of the people amount for 75% of the dollars. So,
do you believe, Howard, that a major part of this problem is the inability of the Congress to separate policy from politics?
I can't figure it out.
I don't either. I don't understand, because I think that the parties, and both parties, in my opinion, are equally guilty, have not worked well together to come up with some kind of compromise that is good for the people.
I would think that the politicians are smart enough to understand these issues. This is not rocket science. If you increase demand, unfortunately, Congress cannot repeal the laws of supply and demand. Even through reconciliation, they can't. If you increase demand by 30 million people without increasing supply of healthcare providers, simple economics says price goes up. Mm-hmm. And it's not like it's so easy to get an appointment with a primary care physician who, that they don't have anyone to see. Who's going to see all these people?
Well, but it's getting hard. I went to the doctor the other day, and he let me know that he did not visit patients in the hospital. He had underlings to do that. Well, I thought, as my little heart began to beat a little faster, I thought, oh my goodness, what if I'm really sick and I'm going to this doctor that I think is wonderful, and if I'm really sick, I'm in the hospital, and he's not coming to see me. What?
In any other industry, if you're a lawyer and you're a great lawyer and you're too busy, what do? You go up on your billing rate to clear the market.
But it's not my insides that were at stake here.
Well, but what I'm saying is, in any other industry, you can use price or choice. You can use things to clear the marketplace. In healthcare, the doctor's only choice is to close their panel. They can't charge more for seeing you in the hospital. They can't charge you a premium price. And that is just contrary to how we do everything else in this country.
Well, and you're talking about your individual policies. Mm-hmm. Some people don't have $550 a month to pay. And well, let me rephrase the question. It occurs to me that people who have company policies are in a much better position to sustain the cost, because often the company, there's such a big pool that we have well ones and sick ones all in the same pool. And if you have two things, if you have your own policy and you buy it while you're well, that's good. If you buy it when you're sick, or you have a pre-existing condition, you often can't get insurance.
And that is a challenge. The problem is the carriers would be happy to waive pre-exes. They just cannot waive pre-existing conditions if people can wait until they're sick to buy. And that's the fundamental issue here that somehow isn't making its way through Washington. No carrier is going to want to offer coverage to people who can wait until they're sick to buy it. And the penalty for not buying it in these plans that are currently being proposed is as little as $200 a year in the first year.
It's cheaper.
It's cheaper to wait until you're sick to buy it.
Opt out, yeah.
Because if you can buy it whenever. What we need to do is get to a point where people realize that they need to have it. How we do that, whether we require everyone to have it, whether we say there's going to be a one-time open enrollment window that you can go buy it today, and if you don't buy it now, forever hold your peace.
But that thought went through somebody's head that everybody had to buy it. But then it was a little footnote, and it said, well, if you're this poor, then you're exempted. Well, that's not good.
Well, one of the other variations is if you're this poor, somebody else will pay for you buying it. Yeah. But you still own it and you buy it and you're back in that
but
pool.
Who is that somebody else?
It's all of us. It's government.
That's right.
We do that today. The reality is, while it's terribly inefficient and it requires someone to go broke, if you have no money, you're on Medicaid. The sad thing for our current system is you have to get broke before you get there.
I was going to say,
and that's what we need to fix. But we do have a safety net. It's called Medicaid. If we think that that safety net is not properly functioning, then maybe we need to fix that.
How? What would you do?
What would I do versus what is
politically
feasible
what would you do?
I would require everyone to have some form of health insurance. I would require it to have a very high deductible, possibly even make that deductible form based on their income, so that if you're lower earning, you still have some skin in the game, but it's more tied to your level of income.
Because people with no skin in the game tend to abuse the system.
Many wonderful stories of that happening, aren't there?
Yes, yes, yes. And it's, I don't know. Let's talk about pre-existing conditions.
Okay.
Some of these people out there that are diabetic, for example, or that have, I don't know, some kind of chronic disease, Crohn's disease, all kinds of chronic diseases, they can't get health insurance, even though, Howard, they can afford to pay.
You would be surprised to know that in many states that have healthy, well-functioning, uninsurable pools, like we actually have here in Kansas.
I want you to talk about that a little bit, that uninsurable pool.
Are somewhat affordable. They're not as affordable as if you had bought the health insurance back when you were healthy. And again, if you buy it when you're healthy, you get into that pool, and that healthy pool, even if you get sick later, that's what you're rated on, is based on that pool. And those pools tend to migrate back to average after about 3 years.
Do they?
Yeah, that tends to be the numbers. But in Kansas...
And you have to be turned down?
If you're turned down 3 times, you can go to the uninsurable pool. And the premium, while it's expensive, it's not outrageous. And remember, it's only covering people who cannot otherwise qualify for health care. But the reason we're able to offer that in Kansas is we have a lot of people with health insurance who are healthy that are subsidizing those that find themselves in these situations.
Do you believe, well, as long as, when the government takes over whatever it is, then, by the way, the subsidy has to come from somewhere.
There are always subsidies.
Yeah.
You know, there's always what the actuaries like to call adverse
conditions.
Well, adverse selection, actually, not adverse conditions. But sure, it's like anything. It's like anything else. If you can find out that it's the all-you-can-eat and you're hungry, you want to go to the all-you-can-eat place. If you're not that hungry, you want to go to the by-the-ounce place. Yeah. And so that will happen as well in healthcare. But the biggest problem I have is none of these programs get at managing the underlying costs.
How do you do that, Howard? What would you do? I'm asking, what would you do to manage the underlying costs?
I find it shocking that Medicare, let's use Medicare because most people understand Medicare.
Okay, okay.
Medicare pays dramatically different prices to various hospitals here in town.
Really? For the same thing?
For the same thing, based on their cost and a whole complex formula. If you were to find out that your doctor practiced at 3 different hospitals and Medicare is paying $10,000 difference based on which hospital you go to, if it was your money, you'd probably go to the cheaper hospital. All other things being equal. Same doctor, same care. In fact, some of these hospitals have multiple hospitals in town. They're all part of the same system.
Well, but what makes the difference in price?
The government formula. When you have a cost-plus based system, guess what you get a lot of? Cost.
Well, let's go back to the government formula. Does the government formula take into consideration how much charity work the hospital does? How does the government arrive at that different formula for a different hospital, where it's located?
It's a very complicated formula as to how they determine what a hospital's, what they call conversion factor is. And then they take that rate and they multiply it by a table based on what the condition is. And there's outliers, so that in case somebody was a little bit healthier than you expect, a little bit less healthy. But for the most part, all people getting a stent and a bypass are going to get paid the same thing at a given hospital, but that rate is different from hospital to hospital. And my point is, if the government were to change the Medicare benefit design to do the opposite and say, we pay X, you want to go to the more expensive hospital, you pay the difference. Well, now I, the consumer, can decide if it's worth it. And the irony in this is how it used to be.
Well, how did we lose our way?
Well, it's a great story how we lost our way. You know, do we have 30 more minutes left? It is actually, the history of all this is actually fascinating. Many people, you've heard, will use the example of which was actually Aetna, that supposedly invented group health benefits during World War II because of the wage and price controls. But the reality is we had different ways that we implemented benefits in the past. We were not as, things did not move at the speed of light like they do today. So out in California, you had Kaiser, which got started back in the 30s. And you had Blue Cross, which got started Blue Cross got started in 1929 in Dallas, Texas, when the hospital in the middle of the Depression was scared to death that they couldn't pay the bills. So they went to the teachers and they said, pay $6 a year and you'll get 21 days of hospital care.
I can do that for my dog now, you know.
Well, what's old is new, right?
That's right.
And so this wasn't all based on wage and price controls and tax systems and things of that nature. We had various ways that all got back to the same thing of the employer paying for your health care. From whether it was through the teachers union because of the teachers cutting deals, whether it was because as the Colorado River was being dammed and Kaiser was paid to cover 5,000 people as they were workers on damming the Colorado River, or whether it was Aetna going to employers during World War II. These were all employer-based systems. And what we evolved to very quickly was what were called scheduled benefits. And you may remember, you used to have a schedule and it said they paid $30 for the office visit. I
do remember that.
$6 for an immunization. And what did you do? You called up the doctor and you said, what do you charge? And if that schedule said 30 and they charged 32, you might have been willing to pay the extra $2 out of your pocket.
I do remember that.
And what happened if they said they wanted 40? You hung up on them and you called the next doctor. And the marketplace worked. Well, the problem is we got to the 70s and we got to rapid inflation. And they couldn't go up on those schedules fast enough. And so somebody, good theme here, unintended consequences, said, well, here's a simple solution. We'll just make it 80-20. Then we don't have to go up on the schedule. Well, now the person making that phone call is only paying 20 cents on the dollar of that extra charge, so they don't care as much.
Cool.
So then we got to managed care to try and get that under control. And we said, tell you what, to make this easy, because all these discounts after the fact, you can't calculate it, we'll make it a $10 copay. Well, $10 copay, it's the all-you-can-eat buffet. Now, I wish I had $10 copays on my cars.
Yeah, me too.
How many cars would I have if I only paid 10 bucks? In fact, I'd be arguing my health insurance, or my car insurance, that it should pay for my new garage to cover those cars and protect them for the future.
But what you're saying is frightening, because what I'm hearing is that we are, in this country today, in health insurance, the victim of unintended consequences.
We are, and we will continue to be. Again, back to Massachusetts. Who'd have thunk, right? You let people opt in and out, that they're going to opt in and out by the month, based on whether they expect to go to the doctor that month. That's
How
what's
long
happening.
does it take to opt in?
Immediately? Well, what happened in Massachusetts, you have guaranteed issue, which means anyone can get it. You have waiver of pre-existing conditions, and you have no mandate that requires you have it. And sounds like the current bill, doesn't it?
It does.
Well, what's happening right now in Massachusetts, again, this is a failed experiment. People are saying, well, let's buy insurance for November. Let's all go to the doctor in November. And then we'll drop it for December and January. Maybe we'll go back in March. Well, it's a fiasco. TennCare in Tennessee, another fiasco. We're going to add more people, we're going to more people Medicaid. We're going to manage the care better. It'll reduce the cost. Financial fiasco. And I'm going to tell you a little story you're going to love.
All right.
Do you know what a ghost is?
A ghost? An apparition?
Let me tell you about another unintended consequence story, ghosts and health insurance.
Okay.
In the military,
I know about ghosts at the table. Maybe there is a ghost at this table.
Well, there may be.
Yeah.
We're going to pick on my friend Ted, who is a ghost. We're going to use him as an example. Okay. In the military build down, when the government was shutting down military bases, you had all of these retirees from the military that were entitled to benefits to go to that military base. Well, when you don't have the base, where are they going to go for their health care? And so the thought was, well, let's give them insurance. We'll go negotiate with the Blue Cross plans, and that actually became, with the various insurance plans, that actually became what was called the Campus Reform Initiative. Sounded good, right? We're going to save all the money of these bases. We'll have to give these people who used to go to the base insurance, and it'll be great. Well, my friend Ted was a great example. He was a military retiree, and he wasn't going to that base. It was inconvenient. He had foundation health plans through his employer, He paid $50 a month. His employer paid $250. Total premium was $300, and he was happy. As soon as he found out he could get it for free because he was a military retiree, he dropped his employer coverage and he jumped into the Champus program. He was a ghost. He popped up out of nowhere. It was an unintended consequence, wasn't it? So they didn't
He and
expect.
a lot of other friends.
Well, there's a lot of people like that, and so what happened was that the cost of that program went out of control because they didn't think, they couldn't see around the corner, could they? Just like that person who said, let's go to 80-20, couldn't see around the corner that it would take away the incentive.
Well, they opened the gate.
And maybe we need to get back there. Maybe we need to have some types of scheduled benefits that say, go back to my Medicare example. We pay X. You want to go to the more expensive hospital, you pay the difference. Let's get the consumer involved.
Well, and then you have people say, well, the more expensive hospital is better, but I don't get equal health care because I can't afford to go to the expensive hospital. I got to go to the cheaper hospital.
I don't necessarily know that the more expensive. Unfortunately, there is no correlation in health care between expense and quality. In fact, sometimes it's the opposite. The volume providers are oftentimes less expensive. And volume
and equally as good?
Volume, no, they're better, because volume equals quality in health care. Who do you want to go to for your surgery? The one who does 200 a year or the one who's doing there first?
Well, the heart surgeons, the more they do, the better they are at it.
And oftentimes the more efficient they are and the more moderate their price is.
Well, this is sort of a parallel, but I was watching one of the programs, and they were talking about this doctor that had come up with a checklist for the operating room. And the operating rooms that opted to use that checklist, have you got this, is this clean, have you done that, whatever, they cut 30-some% down on the infections and the residual awful things that happen to you after you've been in the operating room, just because they looked to see what they were not doing. So that's really what you're talking about.
There are tremendous opportunities to save in the cost of health care. Unfortunately, none of the current bills have anything in them that do that. They're all focused on making somebody else pay, getting everyone into the system. But if you cannot get to the underlying health care costs, how can you cut the cost? You can vilify WellPoint all you want for going up on its rates. But if they're paying $112 for every $100 of premium, they're not going to stay in business too long if they don't go up on their rate.
Well, that is true, and I know that, you know, the government budget office only talks about what it's going to cost the government when they talk about these plans. And they'll say, well, this will save this kind of money, but we don't have to start paying for it until 2014 either. So, you know, there are a lot of unintended consequences, again, with some of these plans. And I think we don't always understand. It's very complicated, Howard.
It's very complicated, but you know what? America knows when they smell a rat, and they smell it on this.
Well, you know what Warren Buffett says? Warren Buffett says that he would ditch the current bills and focused on cost, cost, cost. And he said, I believe in insuring more people, but I don't believe in insuring more people until you address the cost aspect of this. It's just what you're saying.
None of these programs address the underlying cost. And if you don't address the underlying cost, you can't get costs under control. It's simple economics. And on top of that, they're going to give more people insurance, which is going to drive up demand and drive up the cost even further.
Are we going to get this straightened out, Howard?
I've given up trying to predict. I've never failed to be underwhelmed by the wisdom out of Washington, and I have given up trying to predict. There are components of this that make no sense.
Well, I think both parties, if something happens that's positive, both parties are going to have to make up their mind that they will negotiate, and negotiate for the good of the system, and not, they have to separate good public policy from politics. I really do believe that.
You certainly do not have a mandate of support right now.
No, we don't.
This is a major undertaking. And again, if we want to do this because we think it's the right thing to do, then we can have that debate. But people are being somewhat misled when they're being told it's going to save money when it's not. When you've got just a few years of the program and 10 years of the taxes, and you try and add them up and say is comparable, it's not comparable. The analysis that I've seen of the next 10 years, you have 10 years of benefits and 10 years of taxes, it doesn't look so good.
It doesn't look so good, but you know, Howard, I have to go home, take an aspirin, and say thank you so much for talking about health insurance and allowing me to introduce you to all our family out there, because indeed it is our community, and this has been Howard Wizig.
Thank you very much for the opportunity.
Thank you, Howard.